to talk about LV systolic function and cardiac output. So over the course of the lecture, I just hope I can try and persuade you that LV size and function is incredibly important in the critically ill. We need to talk about how to make these measurements accurately, and I think that's a really important part because we are sonographers almost as well as clinicians, and you've got to be able to make accurate measurements if you're going to try and communicate appropriately. If we're trying to do serial measurements on patients, make sure that we are doing things in the same manner each time. When it comes to cardiac output, it's really easy to make errors with that. So we'll try and talk about a few tips and tricks about how to ensure that that's done right. And having an understanding about all of this, about the limitations and assumptions that we make as we're looking at LV size, function, and cardiac output. And if I'm allowed to, I hope it's all right, we might just delve into a little bit of research as we go through this, just trying to show you some of the work that we're doing at Nepean, trying to look into some of this stuff. Okay, the heart is complex. We've got a 3-dimensional structure and we have a 2-dimensional imaging tool. And with the 2-dimensional imaging tool, we actually miss quite a lot of function of the LV, such as the twist and torsion, as they call it. Use the example, if I gave you a towel and asked you to squeeze it, or get the water out of it, you wring it, and the heart does the same. But we don't really see that. We just see, this kind of stuff where we see the heart in 2 dimensions. We see it thickening, we see it shortening. If we look at it in short axis, we see it thickening and turning a little bit, but we miss, some of the evidence says, up to 30–40% of the function of the LV during systole because we don't really assess that twist and torsion. I'm not going to talk much more about that, to be honest, but just to drop that little sort of pebble in the pond, just to say that there is the potential that echo is not describing, or conventional echo parameters are not describing everything that we should know about in terms of how the heart works. The next thought that I'd like to try and put in is to try and say that we also talk about LV size, LV systolic function, and cardiac output. I feel we also talk about these in isolation quite a lot. And I'd like to try, if I can, if there's time, just to drop in the idea that maybe this is also a bit of a fallacy and we need to be trying to integrate these measures a bit more when we're looking after our patients. So we'll keep it simple first of all, and let's just talk about why it's important. Say I'm keeping it simple. I'm actually going to keep it quite complicated if we kick off. I'd like to just share with you something that we've been working on at Nepean. This is very, very unpublished. This is a work in progress. What I want to try and show for you is why this is important, that you need to know about LV size and function. We are working with the National Echo Database of Australia. It's called the NEDA database. And this is the largest, most incredible sort of organization where they've a group of cardiologists, which are Professor Strange, Greg Scalia, and Hugh Playford. Sorry, not Hugh Playford. Oh my God, what's wrong with my brain? David Playford, thank you, sorry. They've got together and got like 70 of the biggest echo labs around the country, and they collect data of every patient that comes in, and they then try and link it with the death registry. So they have very accurate ideas of what the echo data, just the DICOM data, is linked with at least 5-year outcomes, because they've got in touch with all the death registries around Australia. What we've done is we submit our data to that database, but I asked for the data just from the stuff that we gave from our ICU. And so we've got input or echo data, which I think this makes up the largest critical care echo database in the world. I think that's true. And we've got about 1,838 patients from a 5-year period, which is the retrospective time period of the NEDA database. There is a prospective one going on at the moment. And we linked some of that stuff with the ANZIX core database. So we were able to link echo data with physiological data. And through the help of Stephen Huang, who is our scientific officer here, he's been able to do some pretty interesting large data analysis called cluster analysis. And what this is doing basically is looking at all of that data and trying to pick out what is clinically important for these long-term outcomes. So it approaches this stuff with no predispositions, no bias, nothing like that. And it will start trying to pick out clusters of what is important in terms of long-term outcomes of our critically ill patients. Just at Nepean Hospital, it's just those patients that have had echoes So it is obviously a selected population of sick patients, whatever that means, but patients that are basically having echoes. And interestingly enough, it's picking out a range of things which I don't think are too surprising as what you'd imagine to be significant for prognosis, such as age, such as invasive ventilation, such as Apache scores, having chronic renal or chronic respiratory failure. But what's, I think, very interesting about this group is what is prognostic from an echo side of things. So this is the discriminative power of some of the most important variables in there. And one of the strongest in there, right at the top with the black bar there, is ventricular function. Now, this cluster analysis isn't separating out LV from RV or patients that have both ventricular or both LV or RV systolic dysfunction, but it just says that ventricular function is an incredibly important and prognostic factor in our patients' long-term outcomes. And it's more important than, or it's more discriminatory than age. It's more discriminatory than Apache score. And I find that extraordinary. The clusters that it's drawn up from this big data analysis, and again, this is all just please work in progress. I know this will go out on the internet. I hope I imagine not a huge number of people will look at it, but please don't publish this anywhere else. But it finds out that there's sort of three main clusters. And one of the things that's really interesting about this data that we've got is just the same as when we look at a patient, you don't take one thing in isolation. It kind of groups together a whole bunch of things that have almost a probability of causing a significant outcome. And what we see is that LV, RV, or biventricular dysfunction, particularly in this group that actually has a predominance for being male and has a predominance for other things in there, which we'll publish soon, they're all incredibly important. So I guess my intro to this, I use this as an intro to the whole talk, is to tell you that LV size and systolic function, we need to do it properly. It is the first thing that we write about in an echo report. It is the common language we have with cardiologists. Ejection fraction is universally understood. And our data, which I think is some of the biggest data there is in critical care literature, says that it is incredibly important for us to do. So let's do it, and let's do it well. So LV size and function holds significant importance for short and long-term patient outcomes in the critically ill. So how do we do it? Well, let's start with LV size. We can do it in a couple of ways. So the first is we just look at it and you can do a subjective assessment. You've got centimeters written down the side of your, can you see my mouse, by the way? Yeah. So you've got centimeters down the side of your echo image. You can estimate it. I use something like 5.5 centimeters. If it's giving bigger than that, I might go and start doing some measurements. If it clearly looks bigger than 6.5 for men, that is a significantly dilated left ventricle. Okay. If we are going to do serial measurements, we should do some sort of analysis. And that objective measure should be at the tips of the mitral valve leaflets, and it should be absolutely perpendicular to the axis of the left ventricle. Okay. So it has to be at 90 degrees. In the past, we used to use M mode. M mode is now suggested not to be used to make this measurement because it's so subject to errors. Okay, and the error particularly being, like you can see from this image that we've got up here, that if you use the M mode, it is not perpendicular to the axis of that left ventricle. So you go to the end of diastole, which I typically do. It's pretty close to the onset of the QRS. It often isn't. And I wait for where the mitral valve leaflets come together, measure at the end of there. And then at end systole, you do the same point. Okay, so the same areas where you do it in diastole. And from there, particularly if you're using the LV internal diameter during diastole, you can get an estimate of what is dilated or not, right? And classically, they take that, like let's take blokes, the diastolic dimension, they've got a range. And so they will take outside of that range of 58 millimeters is when it starts to be dilated, 52 for females. And that's when it says it's starting to be an enlarged left ventricle. I'm going to go with the premise that if you've got a measurement that's abnormal in one plane, you've got to go and back it up in another. I often back these measurements up if it is dilated or it doesn't quite fit with my eye. I'll try and back it up in the short axis, trying to make sure that short axis is perfectly circular and try and repeat that measurement and check it makes sense. Okay. So I bagged out M mode a bit there. And I don't think M mode is great for that LV size measurement, but I'm not sure we need to throw it away completely. The true M mode that we talk about isn't really available such as it was on older machines. Most of the M modes that we have, frame rates are actually pretty similar to the 2D pictures because the 2D pictures are getting much better, and M mode by itself isn't as perfect as it once was. But it's, you know, it's not perfect because obviously if you just got one line, you can have things flowing in and out of it. That's called translation error. It makes it a bit tricky sometimes to make measurements that are perfect, but it's definitely good for RV systolic function. Does anyone know why it's really good for RV systolic function? Michael, tell me, or Rishi.
I think it's the longitudinal contraction.
Yeah, nice, excellent. Because we measure it from the apex, right, down to the annulus. With the RV in particular, you've got a preponderance of longitudinal muscle fibers. 85% of them or something are in that longitudinal pattern, which means that we use it as a way of estimating systolic function. Is it perfect? Absolutely not. You shouldn't do just one measure in isolation. So, but it's pretty good. And in some MRI studies, it suggests to, outperform other measures in normal patients. I think the areas where it's not perfect, and we'll talk about this at another time, are unfortunately patients where you've got RV dilation, acute pulmonary hypertension, or acute on chronic pulmonary hypertension. These groups, TAPC falls down a little bit, which unfortunately is exactly our population where we want it to be a bit better. It may be useful for LV systolic function in doing MAPC, and we'll go through that in a sec. So here's an example of M mode that pulled out of an echo report from a few years back. You can see that the M mode is vastly off axis. I'm not measuring perpendicular to the LV there. You can see that this patient should automatically be diagnosed with HOCM, of course, because they've got 2 centimeter thick ventricles. Of course, they don't. We're just off axis a little bit. So M mode should not be used in this circumstance. Does it still tell you some information? Yeah, maybe. I think we can still see there's not a lot of movement of that ventricle wall. We still can see that there's maybe not that much of an E-point separation. In the end of the day, I think we've got better ways of assessing some of that, right? So I generally see, we don't see these images much in sort of modern day echocardiography through the LV. All right, so that's LV size. Any questions so far on LV size? So just in summary, measure it at the end of the mitral valve leaflets, parasternal long axis, make sure you're perpendicular, get the end diastole and systole done right. I normally use the mitral valves of opening and closing for that. And I measure it in 2 planes. And you've got to measure it. Oh, nice one. Okay, so why don't we measure it? Who is doing Hey1? Can I ask you a question? So why don't we measure it? I've just talked about the parasternal long. I just breezed over 3 echo windows there. Why are we not measuring LV size in the apical views?
Is it related to the resolution?
Yeah, which resolution?
Because the lateral resolution,
yes,
is, well, axial resolution is better than the lateral resolution, so
fantastic.
You wouldn't want to.
Yeah. Do you remember why? And we're not doing a lecture on physics or anything, but why?
Why? Because of the lateral resolution's determined by the beam width.
Yeah, nice.
but I couldn't
that's perfect.
explain it.
Remember, it's not just a perfect line, and we always think of ultrasound just a perfect line. It's not. It's got this sort of curve in and out, and so the beam width that you've got there is often not as good as the frame. The little sinusoidal wave that you're going to get, which is being pushed out in little sort of sections at a time, and so your axial resolution is much better because the the wavelength is much smaller than the beam width. And so you can pick up things much better in that plane rather than that plane. Good man. Right, LV systolic function. First and foremost. Yes.
Sorry, I have a question about size. It's Emma. So we use these dimensions a lot, right? But the guidelines and I guess our clinical practice, we're moving more towards volumes and especially index volumes. I wondered what your thoughts are on that, because there's often a lot of discrepancy between the indexed volumes and the diameters. For example, it's not uncommon to have someone, male with a end diastolic diameter of 4.8 centimeters. where the sonographer labels them as moderately dilated LV based on index volumes. And I wonder how you deal with that clinically.
Yeah,
and what
so
you think we ought to be doing.
I can show you some stuff that we've done on some of the volumes that I did mainly with 3D, but I think it's really hard to get volumes accurately in the critically ill. You know, I'm just about to say with the systolic function, I think that we steal all the guidelines from the cardiology literature. I totally buy volumes would be great for people who can get reliable ejection fractions, reliable 3D volumes in particular. So they're shown to be more accurate than the 2D. I think sometimes this is not translated easily over into the critically ill. So I guess you've got to have good imaging. How about that? So I think volumes would be the way to go, but you've got to have good images.
Thank you.
Right, LV systolic function. So start with subjective assessment. And the subjective assessment means you've got to look at every single view. That means that the rules is that you have to record your images every single time you turn on the machine. And you need to go and have a look through your images before you start making an assessment. So one of the ways that for systolic function I love doing is the review button on whatever machine you're using. You can go to try and get 16 pictures at the same time up and trying to flick through those pages so that you have something that looks not dissimilar to that. The way that you can have a look at the heart from multiple different angles and try to make an assessment of what you think the patient's systolic function is. And that systolic function is normal or hyperdynamic. So if it's ejection fractions over 70, 75%, it's mild, it's moderate, or it's severe. It is never mild to moderate. It is never reasonable. It is never lower end of normal. It is never severe to moderate. Okay. Now it may be on the balance somewhere, and that's where we've got to use our clinical judgment. In the critically ill, it depends on what catecholamines they're on. If you've got an ejection fraction of 50%, but they're on 5 mics per kilogram of dobutamine and 40 mils an hour of NORAD, that is not a normal cardiac function. That is it's an impaired systolic function on the basis of the catecholamines. So clinical context comes into it, as well as looking at other parameters that we'll talk about in a moment. So I think clinical context comes important. The way that we talk to each other is really important, which means that we need to make an assessment as best we can. You may be sitting on the fence, but you're going to have to make a call. And generally, I find that intensivists overcall these things and cardiologists undercall it. And probably the answer is somewhere in the middle. And whoever's the reporting doctor is usually thinks they're right. So as we look at this, what do you think of the LV systolic function on this one? Umi.
In terms of size, the LV is not dilated. Just by eyeballing, it looks
yep, fair enough.
Size is about normal, but there is at least moderate LV dysfunction and maybe regional wall motion abnormality as well.
Perfect. So would you be happy to do an ejection fraction on this patient? If I gave you
you need more. I think you need more images.
Yeah, I mean, what makes you want to think that you could do an ejection fraction on someone?
I can't. I think it's just lack of my skill. I can't.
It's the same with me, I'll be honest. It's not every time that you can do these. I mean, the basic idea is that you're meant to be able to try and see the endocardial border throughout the cardiac cycle, right? And you've got to see that in the 4 and the 2 chamber. Ideally, you should have, you see this sort of optimized view for a 2 chamber. It should be the same for the 4 chamber, and trying to make sure you can see the endocardial border throughout the cardiac cycle. You don't want to be guessing. We need to ignore the trabeculations, and I guess you either ignore the papillary muscles. Some people include them. As long as you're doing the same thing every time, you should exclude the trabeculations and exclude the papillary muscles, in my opinion. That's what the guidelines say. And measure it as accurately as you can. Okay. The next thing that you should try and check is that during end diastole, that the internal axis of the left ventricle in the 4 chamber and the 2 chamber should be approximately the same. So some would say it's got to be within 5 millimeters. Some people should say it should be within 10% of that measurement there. So if it is 9 centimeters. You should be within 9 millimeters when you measure the axis in the 2-chamber, okay? And that's really important because it makes sure you're not foreshortening the image, all right? Because if you're foreshortening the image, the likelihood is you are going to overestimate what the ejection fraction is. Does that matter in a critically ill patient with septic cardiomyopathy? Maybe, maybe not. All right. I think there are far more things in there. Does it matter for a patient who's maybe got chemotherapy-induced cardiotoxicity from, with breast cancer? Absolutely, of course it does. Does it matter if you're changing treatment from heart failure patients from beginning of the year to midway through the year? Of course it does. So if you are imaging it for, serial investigation, you've got to make sure your ejection fraction is done correctly as best you can. Okay. So the rule is you've got to see the endocardial border, you ignore the trabeculations and the pat muscles, and you make sure that that internal axis is within about 10% of each other. Cool, understand? Brilliant. Okay, Michael, what do you think about this one?
So it looks like the ventricle is impaired, but the images are off axis and it's a bit foreshortened. I can't really see the apex very well, but on the 2-chamber you can see the apex shortening quite a lot. So I think it would be tricky to talk about an EF. I can especially measure an EF in this person. Beautiful.
So I'm sorry I tried to trick you, and well done for figuring all that out. So let me I'm going to do it by interpretive dance rather than go back to the first slide. When the heart contracts, if that's the top of the heart, that's where the mitral valve is, and that's where the apex is, the heart twists down like that, and it's the base that comes down towards the apex. So the apex is fixed and the pulmonary veins are fixed, and the bit that moves is the bit in the middle, the annulus, or the fibrous skeleton. And so if you are imaging correctly from the apex should not move. It should thicken, but it should not move. So one of the things I look at is imagine my thumb is at the top of the picture, and the apex should stay fixed to that point, and the base moves up and down towards it. Okay, you probably see it better in the 2-chamber. Can you see how that apex is moving down the whole time? And if it's moving down the whole time, it means that you are off axis, right? You're not imaging from the true apex, you're imaging from the side, you're foreshortened the image, so you are not going to be estimating the ejection fraction in the appropriate manner. Can you make a kind of guess at what systolic function is? Sure, it's subjective at best. Just don't make measurements, okay? So don't make measurements if the image is not accurate, all right? So if you can't see the endocardial border with decent definition, and for me, that means that if I can't see 2 contiguous segments in either the things, I won't do ejection fraction. Your eye's not too bad after you've assessed maybe 250, 500 cases. You'll get pretty good at doing it. In my opinion, in the critically ill, I do a lot of subjective assessment, okay? And clinical context is more important to me than knowing the ejection fractions 52 versus 54. Tell me if you think I'm talking bollocks at any stage, Emma. Yeah, we went through it. Okay, Rob, how about this one? What do you reckon? I can't remember the clinical story for any of these patients, but it's probably academic, but
sure. So we've got an apical 4 or an apical 2-chamber. To me, the systolic function appears impaired.
Yep.
Probably.
And you're allowed to get away with that as you look at this thing, but as in the exam, you're going to tell me whether it's mild, moderate, or severely impaired, right?
Yeah. So I don't know what your thoughts are, Sam. Well, you just said you do a lot of subjective. So from a visual estimate ejection fraction, I'd probably say it's around 40 to 50%.
Good job. Good job. So I'd agree. I sometimes go for, if you're going to give a range, you might as well just give the value in the middle, which yours would be 45%. And again, it's about communication. I think we are allowed to be, what do you call it? uncertain sometimes in our diagnoses, and that's okay when we're talking to each other. And I think when we're writing reports, though, which are going to be read by the people, we try and be as specific as we possibly can. And why is that? So we avoid ambiguity and we try and help people out. If we're not certain, we can probably try and say, but to the best of our ability, to the images, which weren't great, the ejection fraction looks around about 45%. Further imaging when the patient's stabilized might be useful. Something. The thing that I love doing is contrast. So contrast, it just lights up the inside of the heart like a Christmas tree, and it helps you see that endocardial border just beautifully. And that endocardial border, it ignores the trabeculations. It's where the contrast goes right to the edge. And this is where we should be measuring when we do our ejection fraction, both in the 4 and the 2 chamber. Okay. And that means that we can get quite accurate ejection fractions in there, right? And this is where some of these volumes that Emma was talking about can be seen so much better. And this is absolutely 100% the reference standard. We know that these are much better than estimates that we make on standard 2D images compared to MRI, which is the reference standard, of course. And we can see that we've got a significantly dilated left ventricle with this. But let's make note as we look through this of the apical 4 chamber in diastole, the LV length of 9.9 centimeters. That reduces to 8.3 during systole. And we've got a length in the apical 2 chamber during diastole of 9.3. So that is within 6 millimeters. I'll take that. I'm happy to use that as the ejection fraction. I think very nicely it's been traced out along the internal border in both systole and diastole, which gives us ejection fraction of 48.3. So nice job, Rob. So you are absolutely perfect. So your eyeball is pretty good at trying to pick it up. Okay. But if we're trying to be accurate, or obviously if we're doing this to try and look for regional wall motion abnormalities or to look for clots in the heart, echo is insane. It's just perfect. It's not super cheap, but it's okay. Yeah. Okay. So let's talk about 3D. So 3D is becoming more and more popular, and it is part of standard of care for cardio-oncology patients doing this. So these patients are imaged with transthoracic 3D imaging every time they come in. As Emma was saying, it's really good for looking at the LV size, and it's good for looking at volumes, and it's been shown to be pretty accurate versus MR. We had a look at this in critically ill patients, and let's bear in mind that first of all, it was me who was imaging this. So it's not a sonographer. It was just me who was imaging these 90 patients or so. This was my favorite kind of sample, which is a convenient sample, which means that you have lots and lots of patients in the study and you ignore half of them because they're done on a weekend or after hours. And then some of them you can't do. And you just grab the ones that you can do when you can be asked, basically. And that's fine for when you're just trying to compare two values. And so what we were trying to do here is look at can you do 3D imaging of both the LV and the RV with transthoracic echo? I'm not amazing at imaging, but I'm not bad. And so I'd have a crack at trying to do this on all these patients. And I'd try and do it as accurate as I can. It's a bit of a dodgy study because what the reference standard was to look at what the stroke volume is. Surely the volume at end diastole versus the volume at end systole gives you the stroke volume, the difference between them. And, how accurately does our stroke volume estimate marry up with Doppler being the reference standard? And the answer is it's all over the shop. We've got huge discrepancies in stroke volumes, both for Doppler versus the 3D LV, Doppler versus the 3D RV, as well as trying to do Doppler versus Simpson's biplane. I didn't add in that Simpson's biplane didn't match up very nicely with the stroke volume either, but you've got differences here of plus or minus 25 mils. And if you've got mils of, 60 to 90 mils for a stroke volume, having plus or minus, 20 to 30 mils or 40 to 50% is pretty average. So the conclusion we said is that it's not great in the critically ill. I think what we'd love to do maybe is to try and look back at the question that Emma had, which is how good is it at estimating LV and diastolic volumes? And I think we'll need to try and figure out better ways of looking at the LV to try and determine that, such as with CMR or something. Okay. Any questions so far? Happy with that, with the ejection fraction so far? Let's talk about difficult to image patients. So, cracking question that's been asked several times in the DDU is describe your imaging of a critically ill patient who's difficult to image. You may want to consider a few of these when we're looking at LV systolic function. So, Rishi, we're back to you. How are you going to estimate the systolic function of this patient? Give me some ways.
So first is subjective assessment from
Yes.
whatever image we have.
Yep. Anything else?
Then objective measurements. We have a color Doppler. We can measure a VTI through that. Endocardial definition is not that well assessed, and we are losing part of the apex in both the views. So Simpson's biplane might be challenging using contrast to see if we can get a better definition, optimizing the image with the 2D imaging while doing it as much as possible to get the apex in picture and to make sure we are not foreshortening.
Any others? I mean, call from anyone else in the crowd? What else can we do?
I guess one thing you talked about earlier, Sam, is the MAPC. You can see that the longitudinal function in this heart doesn't look good.
Excellent. Very nice. Anything else?
I guess you would just take everything that you could. Like if you could get like an E-point septal separation and a parasternal long, you could do DP over DT of that mitral regurg and just try to put it all together when you're probably not going to measure an EF.
Fantastic. One of the ones I haven't included in here is also looking at subcostal imaging is fantastic, and particularly subcostal short axis. I find those quite useful. I'm sorry, I forgot to add it in. But when you've got your 4-chamber, you tilt your probe around, you look to the patient's right side to look at their IVC. If you then go and look to their left side, you sometimes get a pretty nice short axis, and that's another nice place to have a look for regional wall motion abnormalities, LV size and LV function.
You can do a toe as well, Sam.
Come on, man. So DPDT, Michael, you mentioned this one. So first of all, can you tell me what it is? I've written the values in there. So what it is, and can you then critically analyze this image?
Yeah, so it's the rate of change of the flow of the mitral regurgitant jet. With a faster rate of change, meaning better LV systolic function, measured between 1 and 3 meters per second. You've got normal values there, like you said. This image.
Why 1 to 3? What's the maths behind that? Why does that work?
There's something about the maths that makes that easier. I don't remember exactly why. It plugs into an equation, and those numbers work well. I don't remember why.
I mean, it's just 4b squared, right? So you can estimate what the pressure is at 1 meter per second. You can estimate what the pressure is at 3 meters per second. So it's 3 squared, which is 9, times by 4, which is whatever that is, 30.
It always gives you 32.
Minus 3 down to something. Say again.
It's always 32.
It's always 32. Thank you. So 32. So you minus the two of them. So you know that there's a pressure difference. Then you figure out how fast it is to get to there. It works really, really well in cath, and it's sort of useless in echo, in my opinion. So it's great to know about though, because you can do it. Mike? What are the advantages of it? Well, hang on. No, I'm going to give you the advantages. The advantages are that you can do it in a critically ill patient when all the other images are a bit rubbish. What are the disadvantages of it?
Well, you need to have good.
There's another advantage, Sam, that's important, I think, in our patient group in particular.
Okay.
Like if you can get a really nice envelope and trace it accurately, it's less load dependent than a lot of our parameters.
Fair enough.
So it can give you a bit more of an idea of the myocardial function, the actual contractility. I like it for that reason and to contextualize it with everything else.
Fantastic. And I'm now going to try and disagree with Emma as best I can. I don't win a lot of these arguments, but I'm going to have a crack at that. So fantastic.
Can I ask Sam as well, in the situation of severe MR and trying to quantify LV function in that setting, when someone's got what looks like a good-looking ventricle that's functioning well, but you're not sure whether it's actually well performing compared to where all that flow is just going backwards.
Yeah, nice. I mean, I guess this is what Emma means by being less load dependent, is potentially this would be better, because I think a normal ejection fraction, or an ejection fraction of 55% in someone who's got severe MR is not normal, right? Particularly not in the acute setting. So in the acute setting, someone who's got an LV that is functioning, you know, with ejection fraction of 55, it should be doing a lot more, because most of the blood's going the wrong way, right? So as Emma would said, it might be better in that circumstance than other measures of systolic function. And that's why the clinical context is so important, right? But I still think it's crap. So tell me why, Michael. So first of all, you're going to use, did you tell me anything so far?
I told you some things. You asked me to critically analyze the image, and I was going to say this probably increase the sweep speed a bit. Why is Emma like dominating me?
Nice. Because look, the thing that I hate about this, right, is that we've got a value here of 654. If I move that cursor just like an infinitesimally little small space, suddenly you'd have like a value of 1500 millimeters of mercury per second. And it's just such a small difference, makes a massive difference. So you need to have a perfect envelope. You need to have a perfectly straight MR trace that's going at exactly the same alignment as your Doppler angle. And you need to have a sweep speed that, I mean, this should cover the entire thing, so that the screen, the Doppler profile should just be that little bit there, so that your measurement, you know, a small change doesn't mean that you get 1,000 millimeters of mercury per second difference. So if you're going to make the measurement, your imaging has to be perfect, which means that your depth should be down to 3.5. You should have one cardiac cycle through the whole frame, and you've got to have a very, very nice, clear line where to measure it from. And that's why it works well in cath, because they can make those kind of estimations really carefully. But in echo, we've always got a little bit of a fudge factor in there. But I take Emma's point. It is less load dependent. All right, MAPC. So I should do more of MAPC. I think it's easy to do. It's M mode. You've got to be imaging from the apex, right? So you've got to make sure you're measuring it in the right area. That annulus is moving towards the apex, so you can't be off axis. You can stick your M mode cursor down through your medial and your lateral annulus, and you measure the distance that it moves during systole. And I think there are normal values that suggest it's greater than 8. Someone says 7. I've read somewhere that it said 6, but I think generally I have about 7 millimeters as being my cutoff for this. And there's some work done by Stephen Huang from this unit that shows it's really good versus global longitudinal strain, which he took as being one of the reference for this group. And we'll talk about speckle tracking in just a second. The reason why this may be useful is because, and the same thing goes for speckle tracking, is that if we look at the myocardial fibers of the LV, the ones on the outside are oblique, as in they sort of curve up and round in these sort of spirals. The ones on the inside are longitudinal. The coronary arteries sit on the outside of the myocardium. So the bits that are furthest away from bits of the myocardium that are furthest away from the blood source are the longitudinal muscle fibers. And so the argument goes that in people who have heart failure, the first fibers to be affected are the ones furthest away from the coronary artery, which is the longitudinal one. So the longitudinal function is the first to get messed up in heart failure. Is that the same case in the critically ill? We have no idea. I think probably not. I think we probably got microcirculation, direct cytokine toxicity, edema. So I don't know whether the myocardial fibers are the first to go in the critically ill, but it is a way of doing it. It works in heart failure. It's linked pretty well with global longitudinal strain, which kind of makes sense because they're both looking at longitudinal function. And he had very nice looking bland Altman plots with only, -4 plus or minus 4% difference in measurements for global longitudinal strain. So it's pretty good. And it's easy, so it's worth having a look at. Tissue Doppler imaging was the other one that maybe hasn't been mentioned yet, which is looking at myocardial. It looks at myocardial speed, so it's in centimeters per second. Let's not forget that Doppler, if I'm allowed to go backwards, Doppler is in meters per second, and the machine says ignore everything that's going, slowly in the 10 centimeters per second range. Tissue Doppler does completely the other way around. So tissue Doppler says only look at the stuff that's moving really slowly in the sort of 5 to 10 centimeters per second movement, which is tissue. So you put it over the medial and lateral annulus and it tells you how fast that stuff's moving. When can you not use this, Rob? When's tissue Doppler useless?
Oh, I'm not sure I know the answer to that. I guess all the usual things of having good alignment, etc. But
nice, fair enough. Give me some anatomical stuff though. I meant more like when would, if you've got a, say you've got a lateral one that's normal at, you know, greater than 10, which is what it should be, and the medial was like 1.
Yeah, so regional wall motion abnormality.
Fantastic. Severe mitral annular calcification. It gets messed up when you've got you know, junctional rhythms, or you've got bundled branch blocks. So yeah, so if you've got you know, severe stenosis of the mitral valve, it messes it up. So you've got to use it in the right circumstances. Sinus rhythms obviously helps. Otherwise you've got to average over, you know, ridiculous number of cardiac cycles. And we all know it from the E prime, but you've also got the S prime on top. And so the S prime greater than 7.5's got okay specificity and sensitivity for a normal ejection fraction. I generally find this is also semi not useful, but it's there if you can't image anything else, it's useful. So it's meant to be less load dependent than other ones maybe as well. I think I probably use it more for the E prime more than the S prime. Okay, really quick, we'll talk about some speckle tracking and then I'll move on. So speckle tracking is a new software from like the last decade or so, where these little speckles that make up the myocardium, we if you sort of look at tiny sort of little sections of them, we call them kernels, and they're like a fingerprint. They don't actually change over the cardiac cycle, and they're made up from constructive and destructive sound waves bouncing off each other. So they've got a sort of unique appearance of different parts of the myocardium, and then the software latches onto those and watches how they move during a cardiac cycle. And if they start at a certain length and then they're a shorter length there, that's a measure of deformation. And because if it's diastole, it's longer, systole, it's shorter. That's a negative deformation because it's smaller. And so we talk about negative values of strain, and the more negative something is, the greater the degree of deformation. That means the better the systolic function. So normal systolic, normal strain, if we talk about global longitudinal strain, which is an average of all the segments in the 4, the 3, and the 2 chamber, talk about a normal being about -17. If the better the systolic function, the more negative it becomes. So like a -25 is sort of a hyperdynamic ventricle, as opposed to -10, which is a terrible functioning ventricle. You can give yourself pretty diagrams where it's like you've taken the heart and just sort of squashed it down and then look at it head on. So you're looking from sort of the apex up. So the apex is in the middle and the base is at the side. And you get pictures where if it's red, that's normal. If it's white, it's not moving at all. If it's pale red, it's somewhere in between. If it's blue, it's going the wrong way. So it makes some pretty pictures. You get pretty curves. We can do some research with it. I don't know whether it's fantastically useful in the critically ill, but we are doing some work in that. It's good for the RV because it's a bit easier to do because you only need to look at 3 segments. And again, we'll talk about this some other time. But it's there. And if I have time and I've got a bit of time to geek out, I'll tell you why I think it might be useful in this talk. But that is also in there. You need really good images to do it. You need really good training to do it. You should not be doing this unless you are really good at 2-dimensional imaging and all the other things that we've discussed. You should have done, you know, you should be really good with Doppler and really good with a comprehensive echo imaging before you start doing this. And if you're going to do research in it, you should probably do about 200 studies before you do research because it's a bit fiddly. We'll talk about it some other time. So cardiac output, I think probably with this audience, I don't need to go through this too much, but just for completion, I might just rattle through it. So cardiac output is the sum of heart rate times by stroke volume. Heart rate is obviously given to us when you connect your ECG dots. Stroke volume is made up by looking at the LVOT diameter. We then pretend that that is definitely a circle, and we can then estimate what the area of that circle is based on pi r squared or 0.785 times the diameter squared, whatever you want to do. and then you can times that by the distance that that sort of part of blood that's at systole moves during the systolic cycle. And that distance is the velocity time integral, or the area under the curve of a pulse wave Doppler, okay? And that's how you get your stroke volume. So to do that, you have to do it accurately. If you do it inaccurately, you're going to get inaccurate measures. And the first measure that you have to get right is your LVOT diameter. You must zoom in on that, and you do that zooming in live, because then that what it then does is it has a very, very high frame rate. You see, I've got a frame rate of 105 here when I've zoomed in on that aortic valve, as opposed to frame rates of about 50 if you're in another picture, you know, the big zoomed out picture. You then scroll through that, trying to look at where the insertion points are of the non-coronary and the left or the right coronary aortic cusp, and you put your markers somewhere within 5 millimeters of where they insert into the LVOT. Normal values are what, Umi? What's a normal LVOT diameter? And you can phone a friend. And that friend should be Hey One, I vote.
Okay.
Is it less than 2.1 or something?
Yeah, about 2.1.
Yeah,
Very nice. So I use as so if you've got a small 80-year-old woman who's got an LVOT diameter of 2.5, the probability is that you've got that measurement wrong. So I think it's important to know what kind of normal is. It's about 2. And if you're small and tiny, you should have a small LVOT. And if you're big and massive, you should have a big LVOT. But it should be somewhere around about 2, you know, 2.2. 2.4 would be getting big. 2.5 is enormous. 16 is really small. So you kind of have to, I try and measure this as accurately as possible. Don't make this up. If you're not certain where it is, don't try and make it up. Once you've done that, then you've got your LVOT diameter. You can then do pi r squared with the radius if you divide it by 2, or 0.785, which is just pi, the square root of pi times by the diameter squared. And then you can go and try and find out what your VTI is. So you need to do your apical 5-chamber view for that. So tilt up from a 4-chamber view, and you see your aortic valve come in. I then push my aortic valve over onto the left side of the image, because if you have a look at your color Doppler box that's over your aortic valve, you see that the direction of the blood flow needs to be directly towards the top of the image. And blood flow tends to sort of come, in normal blood flow, tends to sort of come out at a bit of an angle through the aortic valve. So if you follow where that line of interrogation is, hence you move the aortic valve over to the left side of the image. Okay. You're going to want to put your pulsed wave Doppler gate. So you're only going to focus on blood flow through the same place that you measured the LVOT diameter. So where you measured that, at the base of the aortic valve cusps, is where you want to put your little cursor. And how do you know that you're in the right spot? Is because you get a closing click, which I could probably get a better picture of this, to be honest. Normally a closing click is a little bit better seen than that, but you get the idea, right? So there should be a closing click. You don't want to see an opening click. You don't want there to be any clicks. You just want to see a closing click, because that tells you you're measuring your VTI, which is the area underneath the curve, and the same places where you're measuring your LVOT diameter. Okay. Now, Doppler profiles need to be imaged properly, which means that you should have the base towards the top of the screen. You should have what you're interested in filling the screen. You need to have your gain turned down so that you're picking up the brightest portion of that curve. You don't want the beard, you want the chin, is what they say. So turn down the gain till you've got the brightest part, which is called the modal velocity. And 3 cardiac cycles per frame, and measure 3 of them and take the average. Okay. Let's see the closing click. Normal, about 18 to 22. Okay. So once you've done that, you're going to be able to try and figure out from your VTI what your area of the LVOT is. You add that in, times that by the diameter of the LVOT, gets your area times by the VTI, which is the distance, times them together, you get your stroke volume, times by heart rate, you get your cardiac output. So it's all a bit of, it's got some assumptions in there, and it's got some potential sources of error. So the assumptions are that the LVOT is circular, and it's not always circular. The second assumption is that the machine, just like your partner's, thinks you're perfect, which means that it thinks that your Doppler angle is absolutely in line with where the blood flow is. You've got to put your gate at exactly the same place that you measured your LVOT diameter, and you've got to make accurate measures of both your LVOT diameter and your VTI. If you get your LVOT diameter wrong, remember you're going to be squaring that result. So if you get your LVOT diameter wrong, it's, it's all over the shop. For example, here, if I had a LVOT diameter of 2.1 and I'm measuring it correctly, where I've got the gain turned down, I've got my sweep speed correct, I've maybe turned down the filters, the low velocity filters. I'm measuring this properly, I get a VTI of 27.2. If I measure it very badly, I can get a ridiculously, with too much gain. I'm measuring the beard, not the chin. I'm not measuring it accurately because I've got too many cardiac cycles. I can easily overestimate what the VTI is. Okay. It's really important to know about this as we're going to get into valvular analysis because of the continuity equation, and that's how we estimate what valve areas are. So you must be good at this. But in reality, in real life, I probably use the VTI more than I do the stroke volume because I avoid the errors that I will make with that LVOT. So where possible, I use the VTI alone. Okay. Might leave it at this next bit if that's okay. So where do we get up to? Rishi, which of the following is a patient with sepsis and a hyperdynamic heart? A, B, or C?
Sorry, I didn't understand the question.
So you got three patients here, okay. Patient A, B, or C. I've given you what the diameters are. I've given you a VTI. I've given you an LVOT Vmax. I've given you an aortic valve VTI, and I've given you an aortic valve Vmax. Okay, so I've given you some ways that you can estimate what stroke volume would be, and I've also given you some of the continuous wave Doppler through the aortic valve to give you an idea. So bear in mind, whoever the next person is, which I'm guessing might be Rob, is going to tell me which one of the patients with aortic stenosis. So if you've got a patient with sepsis and a hyperdynamic heart, they're going to have a hyperdynamic circulation, right? So I guess another way I could ask this question is which patient has an elevated cardiac output? Which patient has got an increased stroke volume?
Looks like A.
Nice. So they've all kind of got the same LVOT diameter, but A has a much larger VTI. If you've got a larger VTI, that means you've got more blood traveling that distance. So, it's that's suggestive of a high stroke volume. Okay. If you've got a high stroke volume, that will also give you a high gradient across your aortic valve. And this is one of the things we have to remember when we're trying to estimate people's valve areas with echo, is that we can overestimate their stenosis severity if you go on gradients alone, if they're hyperdynamic. And the flip side is you can underestimate the severity of the aortic valve stenosis with a ventricle that is not functioning well at all. That's the low flow, low gradient aortic stenosis. So it is important to understand that flows, or the loading conditions make a difference. Rob, tell me which one has aortic stenosis?
C.
C, nice. So we've got a low VTI, so that means that the stroke volume is actually reduced, but despite that, you've got a very high aortic valve VTI, which would tell you that that is ridiculously high. That might be fine if you had a VTI of 35, but you don't. You've got a low VTI, which tells you that the aortic valve stenosis is patient number C. Well done. All I was going to say at the end, and I was going to geek out a little bit, but I'm not going to now, is just one of the things that we don't do very well is link up systolic function with assessments of afterload, sort of ventricular arterial coupling. I don't think we know exactly how to do that well. There is some evidence out there which says that, things like ejection fraction are very much linked with estimates of afterload. And I think this is important to look into. One of the ways we might be able to do that was with speckle tracking, and I'll talk about that at another time. But I think it's a nice area to think about how we shouldn't be taking ventricle size and function in isolation. It is part of a cardiovascular system. And I think that might be useful in terms of trying to choose catecholamines for our patients and trying not to flog the heart too much. But I don't know the answer to any of that, and it's very research-based. I hope that was useful. Are there any questions that anyone would like to ask? Or any comments from Emma or Ben?
Sam,
I have a question.
Say to... Oh, you go.
Oh, sorry. The only question I was going to ask Sam is, do you in practicality do a Simpsons biplane? And the reason I ask is because I find that you can that, but also you can, the guidelines say to trace out the compacted myocardium. I find that a very difficult thing to locate without the contrast. And you can change someone's degree of dysfunction very easily by where you trace it. And it's, so what are your thoughts on that?
So I don't do ejection fraction as a standard part of my day-to-day echoes on the unit, because generally I find it takes a bit of time and it's not always changing my assessment. I think it's important for doing things like routine follow-up of heart failure patients. So I do it all the time when I'm reporting echoes for outpatients, because we're comparing one thing to another. I do it if I'm talking to cardiologists, and again, in sort of reporting outpatients, because GPs, medical students, respiratory physicians, they all understand it. And that was for you, Ben. And so I think if we're talking amongst colleagues, people like ejection fraction, they understand it. In a critically ill patient that I'm caring for, I don't often do it for all the reasons you just said. It's not always easy seeing that anterior wall in the two chamber. Trying to find the myocardium is a bit hard. If I'm doing contrast, I'll do it, because then it's super easy, right? You can do it really fast because it's easy to see. So it's not a standard part of my sort of life in day-to-day management of critically ill patients, but it is for the echo lab. Ben, sorry, I cut you off there.
No, I was just going to, just a very quick comment that when doing cardiac output stuff, remember that the LVOT diameter, it doesn't change. Once you're another, it won't change. So if you're measuring it and for the people that are starting, if you're measuring it and you measure 2.2 centimeters and you look back over past scans and it's been consistently 1.7, 1.8, 1.9, 1.8, you're wrong.
What a great comment. And that's why I think in the critically ill, what I measure all the time is LVOT VTI, and looking how that changes, particularly looking at, to myocardial function, trying to use that in there. I think it was someone said that Rishi, you were saying that you said that the cardiac output was a measure of LV systolic function. And I think that's a really interesting idea, because I'm not sure that it is. It could be when you're looking at the change in something. So let's say you're a change in VTI when you've added in dobutamine to a patient with a septic cardiomyopathy and you see it go up, that could be an indication of improved systolic function. But just looking at someone who's got a VTI of 18 and say they've got a mildly impaired systolic function doesn't work because of the coupling, right? And one of the things I was hoping to try and do in this lecture, and I'm sorry I ran out of time, was try and show you different clinical scenarios where you've got someone who's got totally weird looking LVOT VTIs despite a normal functioning ventricle because of the reduced afterload that we've done just because we've given them an anesthetic or something. You've got to take the cardiovascular system into, you've got to take flows into reaction with how much the systolic function is going of the heart. And if you've got a low afterload, you're going to get blood sort of being stuck through as opposed to increased afterload or it would stop it, So it's, it's about integrating the findings, and I'm not entirely certain how to do that yet, I'll be honest. But I think when you're looking at how a patient changes over time, I think that's important. Everyone happy? Thank you very much for joining us for our first DDU session. They'll be happening every week. I'll try and get other people talking, other sort of local experts like Emma, like Ben. I'll try and get Chris Duncan talking, a few cardiologists. And they'll happen every Friday, rain or shine. Maybe we'll take a break for Christmas or New Year, but they'll be every week up until the DDU. And in the last 2-3 months, it's just be cases. And Rob, all of these will be recorded. I'll hammer you, and we'll try and do some practice writing questions and get you through the DDU. And happy days.
Thank you so much, then.
Nice to see you guys. Take it easy, okay?
If you learned something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.